Hello and welcome to TMJ Unpacked. This is a space where we look beyond the teeth and start to understand the bigger picture behind jaw pain, facial pain, and sleep. Because sometimes what we've been taught doesn't fully explain what our patients are experiencing. And sometimes the answers are not where we've been trained to look. So, whether you're a patient looking for clarity or a clinician wanting to think a little differently, you're in the right place. So, today we are talking about something that often gets missed in TMJ care, that is hypermobility. And more specifically, what happens when the problem isn't simply muscle tension or overuse, but a system that may lack stability altogether because some patients don't follow the classic TMJ pattern. Their symptoms shift, their joint mechanics feel inconsistent, and traditional approaches don't always seem to help in the way we expect. And when that happens, it forces us to start asking different questions. To help us unpack this, I'm joined by someone who has extensive experience in temporomandibular disorders and craniofacial pain. Dr. Tracy Davidian is highly trained in temporomandibular and myofascial pain disorders and is a diplomate of the American Academy of Craniofacial Pain. She has also received advanced training in sleep related breathing disorders and continues to stay deeply involved in ongoing education in craniofacial pain. Also, I want to share something personally. I've had the opportunity to work with Dr. Davidian and I still work with her. And I've seen firsthand the level of thought, care, and attention she brings to her patients. She's not only incredibly knowledgeable in this space, but also a genuinely kind and a thoughtful person. So, Dr. Davidian, thank you so much for being here.
You're welcome. Thank you for having me.
So, Dr. Davidian, most, TMJ conversations focus on tight muscles, clenching, and overuse. But I've seen that some patients don't fit that pattern at all. Their jaw clicks, it feels unstable. Sometimes it even feels like it moves too much. And those are the patients that really make me pause. So, in your experience, how often is instability, not tightness, actually the real driver?
I feel like a lot of patients that I see, especially I feel more recently, are presenting with some form of hypermobility, hyperlaxity of the joint. I mean, you can have it in one single joint that has an issue that's dislocating or, subluxating at the maximum opening, which the pain sometimes is often on the opposite side when that happens because of the pull. But I find that I have a lot of patients that I'm having the conversation with wanting to dig a little deeper into their medical history to see what other connections there may be as to what could be driving what's going on in the jaw that I'm seeing.
So let's paint a picture for the listeners. So when a hyper mobile patient walks into our office, what are the subtle things you're picking up on even before you examine their jaw? Like, is it posture, movement patterns, the way they sit in the chair? What is it?
I always will look at their thumbs to see if their thumbs look hypermobile. That's one of the first things I'm always checking. I look to see if they're posturing in the chair, holding, have their head propped in a hand as if like their
Mm-hmm,
head might be just so heavy. Their muscles are
hmm
tired of holding it up. If they're
hmm
standing or with our cervical range of motion pictures, I look to see how well they can move their neck. That can show
hmm
signs of hypermobility in the neck area. I look if they're standing to see, what their posture looks like, forward head posturing, if their knees look like they're hyperextended, sway back, all of these different things where the body repostures to try and help support
hmm
the joints from dislocating or just the muscles or getting tired too for the head from having to hold the head up for so long.
And with hypermobility at its core, is this more of a ligament problem or do you think it's more like a neuromuscular control issue?
I think it ends up being a little bit of both. Neuromuscularly, your muscles, get overworked by trying to stabilize a loose joint. So I
Mm-hmm.
want you to kind of think of it in terms of a tent. So if you have a tent with the pole in the middle, just like normal, we all put up tents. You tighten up the ropes to kind of get stability for the tent. But if the problem isn't how tight you're doing it, but it's the pole itself, the pole is wiggly, it's
Mm-hmm.
loose, then it doesn't matter. You're going to keep pulling tighter and tighter on those ropes to tighten to get stability of the tent so it doesn't fall over. So we
Mm-hmm.
have to kind of look at, okay, are your muscles sore and tired because they're working so hard to do the function that you're asking them to do, talk, eat, but then at the same time, they're splinting to protect a joint and keep it stable while you're doing the function. So
Mm-hmm.
that's where the difference comes with a patient who has instability of a joint versus someone who just has overuse of a muscle from clenching because they're
Mm-hmm.
stressed out.
And is there any kind of tests that you do that would help you? So basically, how do you differentiate between a muscle that actually simply tight or and a muscle that actually protecting that loose hypermobile joint?
So that kind of goes into patients who want to stretch because they feel like my muscles are tight. So I'm going to stretch my muscles. You're not going to, your muscles are going to be more sore or when you're
Uh-huh.
doing that because those muscles want to stay tight because if they overstretch they're afraid you may subluxate or or dislocate. Tests to do is when a patient's open wide to see if they have the extra range. I'll push
Mm-hmm.
on the jaw to see how much more the patient has. If it feels loose,
Mm.
if it doesn't feel stable in there, that means the
Mm-hmm.
muscles, they're trying really hard, but the problem is in the joint itself,
Mm-hmm.
not the
Mm-hmm.
muscles. The muscles can
Mm-hmm.
only do so much when it's an internal issue for the joints. I'll always have a patient open, look to see if they're dislocating at the maximum opening. And then I'll even see if when they're at their maximum opening, they may not be dislocating it, but I'll see how much more room they have. So yeah, there's certain tests like that that I'll do.
And because we've seen patients who've been told for years that they need to relax their jaw, but the moment they do it, the joint feels even worse. Can you explain why does that happen?
Because the muscles, and you're asking a patient to relax muscles that actually need to be more stiff in order
Mm-hmm.
to keep the joint in place, the disc in the joint. So if you're asking a patient, let me see if I can give you an example. You have a loose seat belt on, okay?
Mm-hmm.
It's very
Mm-hmm.
loose. You're driving in a car and the you're going to hold tighter and you're going to grip tighter onto that car wheel to keep stable, which is going to create more muscular tension because the
Mm-hmm.
seatbelt's not there to protect you. So the
Mm-hmm.
joints got the instability and the muscles are working harder to keep that area stable, just like you would holding onto a steering wheel.
And at what point do you start thinking like beyond localized TMJ and consider like hypermobility or like even EDS, Ehlers-Danlos syndrome, could be affecting the joint? And what are the red flags that clinicians should actually really start paying attention to?
Medical history. We
Mhm.
all need to pay closer attention to the patient's reported medical history. And I know personally in my office that my team, they do a thorough job of asking questions before I even walk in the room, of past medical history, past social history, all of that to try and connect all the dots. But there are many times I go in there after we reread through them that the patient is identifying other things to me that have happened in their life. But then I'll dig deeper and ask about their digestive stuff. Because most patients, if they don't feel like it's a part of their face and head, they may not tell you about other things like digestive,
Yep.
if they have been told they have leaky gut or IBS, all of these things. EDS or hyperlaxity syndrome is a connective tissue problem. And
Yes.
so you have connected tissue all over your body. It's your blood vessels, it's your skin, it's everything. And so you have to dig deeper and to find out what other things is going on in the patient's life that none of the other doctors are connecting all the dots. And what we
Mm-hmm.
have to be, it's important for us to help be that quarterback to try and connect everything. We may have to get them to go see someone else about another issue. But by connecting those dots is hugely important for the patient because EDS and what people need to know is if you have been diagnosed with EDS or hyperlaxity syndrome, there's not a fix for that. I mean, it's a connective tissue disorder. So it's really important that the patient understands that it's their day to day things that a lot of times can trigger a flare,
Hmm.
the foods they
Yep.
eat. So it's really just asking the deeper questions on, dizziness, systemic type questions, get outside just the face and ask, all how it relates to everything else.
Let's talk a little about treatment challenges. So, one thing I think about is like a lot like why we have these traditional flat, plain splints sometimes fail, or even they can worsen a hypermobile patient. Is it because I'm wondering if we're giving a loose joint a smoother surface and unintentionally allowing even more uncontrolled movement? Do you think that's like a real concern? And what should a dentist be made aware of when they're just giving a flat plane splint to a hypermobile patient?
Absolutely. One size does not fit all. What the muscles need is to relax. So when you put a patient in a flat plane splint and you've got all of that hyperlaxity and hypermobility of the joint, the muscles have, I mean, they're constantly trying to stabilize because the jaw can move all over the place. And
Mm-hmm.
so, what you would like to have is more of a pinpoint stopping point for these patients. So, preferably if they're off the disc initially, you would want them to be on the disc with the appliance in place because
Mm-hmm.
that's going to provide that security for the muscles. Their muscles are going to always, if I palpate them, they may be mildly tender because
Mm-hmm.
they're always going to be working a little harder during function than
Yeah.
someone who may not have those issues. However, during times of rest, if they clench down on that appliance or even lightly rest down on that appliance, the muscles don't have to work as hard to keep the disc and the joint in proper relationship because
Mm-hmm.
the jaw knows exactly where to go. It's got a resting point that is more
Mm-hmm.
stable. So yes, no flat plane appliances for those patients.
Where does prolotherapy fit into your thinking when the problem is instability? And how do you think about that compared to treatments like Botox, especially if muscles are already compensating for laxity?
That's always such a hard conversation to have with patients because they come in and many times they've already tried the Botox piece anyway. And Botox can help provide them with some mild relief of muscular tension. The negative impact of that though is, what have we already established is that we need the muscles to be effective to create better stability for the joint.
Yeah.
So if you are paralyzing the muscle with Botox, you're essentially doing harm to the joint. So
Yeah.
prolotherapy is opposite in the sense that it's the clinician's attempt to try and produce a natural inflammatory response
Hmm.
that can then help to tighten up the ligaments to produce more healing in the joint. And now it doesn't work in every patient, but I have personally seen it work for patients.
Hmm.
And so it is always worth uh, trying to speak to the patient about it and recommending on those
Yeah.
patients that are dislocating or having, ongoing stability issues. And it would likely need to be repeated in the future.
So it should be more of talking about prolotherapy than actually doing Botox in such patients.
Oh, yes, absolutely. You would not want to do Botox. They are not the candidate for Botox.
Dr. Davidian, thank you so much for being a part of this conversation. Now, if this episode made you think a little differently about TMJ and facial pain or joint instability, that's exactly the goal. Because these conditions are rarely simple and they're almost never just about the teeth. Sometimes the problem isn't just tension, sometimes it's instability, sometimes it's compensation, and sometimes the body is trying to protect a system that no longer feels stable. And the more we understand that, the better conversation we can have with our patients. If you found this conversation helpful, you can share it with someone who might benefit from it. And if you're a clinician, I hope this gives you a different lens to look through in your next patient. This is TMJ Impact, and we'll see you in the next episode.